Welcome to the ACP for AA podcast. ACP for AA is a national education initiative of Heart Tones, promoting informed healthcare decision-making through advanced care planning conversations. This special 4-part podcast series highlights conversations with people who are working to close the healthcare disparity gap for African American families and communities. Today's episode is hosted by Heart Tones Executive Director of Communications, Tracy T. Holloway, with special guest, Dr. Jeffrey Coleman, a team physician at Montgomery Hospice and Prince George's Hospice, speaking about the importance of having the ACP conversation. Let's take a listen now.
This podcast is brought to you by a collaborative partnership with Montgomery Hospice, Prince George's Hospice, and Heart Tones Inspirational Company to raise awareness of advanced care planning for the African American community. My name is Tracy Holloway, and I will be your host. Have you ever thought about how or if you would ask your parents, spouse, children, or relatives questions about advanced care planning? Do you have an understanding of what it really means to make end-of-life healthcare choices? Do you know what is really involved in getting your house in order while you still have time? If you are like a majority of people, you might feel uncomfortable talking about death and dying, in particular where it involves your death or your dying. Or like many, you may not know the steps to make critical end-of-life choices ahead of time. For a great number of people, though, simply starting the conversation with loved ones is the hardest part. We want to help you through that hard part in this episode. So today, we'll talk about how to start a conversation about advanced care planning and end-of-life healthcare decisions with those you care about and who care about you. This topic is so very important, we felt it was necessary to call in an expert in hospice and palliative care to help us dive into it more. My guest has been working with patients and families for many years. He's practiced medicine in several states, including Wisconsin, Virginia, Maryland, and internationally in Kenya and Sierra Leone, Africa. Please welcome our guest, a team physician at Montgomery Hospice in Maryland, Dr. Jeffrey Coleman.
Thank you very much. Appreciate it.
Before we get started, let's listen to this quick clip of a talk between a mother and a daughter having a conversation about end-of-life care concerns. And as you listen, audience, I want you to make a mental note to self before we continue. What was the goal? Was there a solution? And what's next?
Mom, I've been thinking, remember last week when they rushed Miss Williams to the hospital and she was calling people other people's names and acting like she didn't know who she was? That kind of scared me, and I've been thinking, what would happen if you couldn't speak for yourself if you got sick or had an accident? What would you want us to do?
I ain't sick. I don't plan on getting sick. I'll be around here a long time to cook sweet potatoes and greens and cake and all that good stuff, and don't worry about that. And furthermore, Miss Williams been sick for a long time. She's been calling me Mama. You and I both know I ain't none of her mom.
That's my point, Mama. What if your memory does start to fade or something happens? God forbid, but we don't know what the future holds. And I just don't want to be where Miss Williams' son is right now. He don't have no durable power of attorney for her healthcare needs, her financial needs, and business decisions. And she is out of it. And then she don't realize how hard it is on her son.
Well, I know one thing. I don't want you trying to put me in no nursing home if something doesn't happen to me.
Mama, now you know we ain't gonna put you in a nursing home, but we need to know what you want if you can't speak for yourself. It'd be too many families start fighting over this stuff when it happens, and I don't want to see that happen to us.
What y'all trying to do with me then? I done told you I ain't sick. I don't plan on getting sick, and my memory is sharp as a tack.
Oh, why you gotta make this so hard? I'm trying to make sure that if that day comes when you're not able to do things for yourself, we have your business in order the way you want it to be. We ain't trying to put you away nowhere. We just want to make sure you have things the way you want it.
Yeah. It's already the way I want it. I'm happy, I'm healthy, and I'm hoping that I never have to go to no nursing home. So you just remember that.
Oh, okay, whatever, Mama.
Oh, Mama, nothing. I'm sick of y'all.
Okay, let's unpack what we just heard. Dr. Coleman, upon hearing that clip we just shared, what are your most immediate insights on that?
That is a typical discussion that you will hear among family members when talking about end-of-life decisions. Someone may be feeling uncomfortable about talking about dying and death. But as I've often heard, no one gets out of this world alive.
That's a good point. That's a really good point. I did ask our listeners to consider a few things: the goal, the solution, and next steps. But we didn't actually hear all of that in that conversation. The goal seemed to be to find out what her mom wanted, but I didn't hear a solution or next steps. So how typical is that to essentially get nowhere fast with difficult conversations like this?
That is often the case. I try to tell people that this is an ongoing process more than anything else. I am glad this young lady started the conversation in the first place. At least it got her mother starting to think about it and maybe can get back to it another day. So I think it is an opportunity and a start for something. You did learn one thing out of it. She doesn't want to go to a nursing home.
Right. She did get that information out of it. And I agree that it may actually be a conversation that you have to come back to and maybe get bits and pieces. It's a hard conversation to start. What are some of the roadblocks that you've seen to having the conversation just based on your experience?
Well, there are many roadblocks, but I've come to the conclusion that these roadblocks are more like challenges that have been put before us because the healthcare system has failed us. And by that, I mean, in particular, African Americans. We have often been excluded from treatments, from hospitals, discriminated against in multiple different ways. And so people have a generally mistrust of the healthcare system in the African American community, that we're being experimented upon, not getting the latest treatments, not being able to go to certain hospitals. And those sentiments remain to this day. And there is truth to it along the way. So I think the healthcare system has failed us. The other part is that many people in the African American community are very spiritual. They believe in God. Primarily, people of African American descent are Christian. And in this group, we believe that God is omnipotent. And so in that regard, he is the one that is going to decide when life begins and when it also ends. He is the author and finisher of our faith. So that in itself, too, is why should I decide instead of some healthcare provider talking to me about it. Thirdly is paperwork involved. Many times when we have these conversations, especially with providers, well, first of all, we don't know where to go or what needs to be done because it's something we don't talk about. And then we have to fill out papers. Do you have to go to a lawyer? Do you have to get this thing called the healthcare power of attorney? How much is that going to cost? All those factors come into play.
Right. So what I'm hearing you say is there's a mistrust of the healthcare system, and then there's also a connection to a personal or faith-based concern or taboo, maybe in a sense of taking that role of caring about your death away from God, who is ultimately responsible or in charge of that, and also a discomfort or a lack of understanding of the process itself that are roadblocks.
Right. For example, as far as mistrusting the healthcare system, most people know about the Tuskegee experiment where they let men from the 30s have syphilis, did not treat these people with penicillin, and wanted to see what the natural course of the illness was. And that lasted for 40 something years, and that study was finally terminated in the 1970s in many of our lifetimes. This is 2020 currently, and this is the 100th year of the birth of Henrietta Lacks, who was a Baltimore native, young Black woman who went to Johns Hopkins Hospital and was treated for cervical cancer. But during that process, they harvested some cells from her in her biopsy and have used those cell lines that they've cultured and grown to this day. In fact, if you've had a flu vaccine ever, they probably were from these cultures from Henrietta Lacks. Now, why is that important? It's because the Lacks family has never gotten any credit for it. They never received any reimbursement, and Johns Hopkins and many big pharma companies have used these cell lines for years and made literally billions of dollars. Billions.
Right. Billions with a B.
Yeah.
Wow. It's really disheartening to hear stories like that as it relates to the healthcare system, because it does create a sense of mistrust, and it's validated. As you said, we know about Tuskegee. We've learned about Henrietta Lacks, and there are other issues as well that even happen now that are sources of disparity within healthcare system alone. But even with those roadblocks in place, a person should still make an effort to have these advanced care decisions done. It's important. How many times and how many ways should a person try to overcome those hurdles to planning for their end-of-life care needs?
Well, first of all, let me kind of define what advanced care planning is. It's the healthcare people wish to have if they have a serious or a chronic illness that's consistent with their preferences and values. Some people will want, quote, everything, unquote, done. Other people do not want to be on a machine or a ventilator at the end of life. And these documents or this process is about preserving the patient's choice along the way. The problem is talking about it or making these decisions. Among African Americans, bringing it up in families sometimes is a difficult subject, because some will feel that somehow you're interfering with God's will. And so this can be a barrier along the way. In addition, as I said, the healthcare system has not served us well. And so when we see a provider and they start talking about these end-of-life issues for 5 or 10 minutes, it's like, you want me to sign something so that you can put me away into a nursing home or whatever. So a lot of people don't know how to providers don't know how to have that conversation or even to bring it up. And it's the same way in families too, but it often is done in a very hurried process in that case. And that's why it takes time for people to get used to the idea that they can really benefit their families from doing some advanced care planning. They can take a lot of suffering from decision-making off of their children or their siblings or their spouse along the way. And generally people that have this done have better mental and psychosocial outcomes, as well as their families. They have less pain and less suffering along the way. And I think that that is something everyone should want.
Certainly, better outcomes, less pain, less suffering are some pluses to having the conversation that's already very difficult to have for many families. Additionally, just from my own experience, what I've seen is, and also heard from others, is that there tends to be drama and discord within the families when these decisions are not made in advance. And sometimes, having the decisions made in advance is not only a better outcome for the patient, but also a better outcome for the families, because they will know what the patient's desires are for their health care in the event that they're unable to tell them and speak for themselves on that situation. And so I think that is also another big benefit to having this conversation. Now, Dr. Coleman, your medical career actually has been greatly centered around your passion for direct patient care and for home visits, but you've also worked in emergency medicine, family medicine, and preventative medical care as well. So what actually drew you to the work that you're doing right now in hospice and palliative care?
I got into this about 20 years ago from exactly what you said, really is from some family drama. In this case, I was at a rural health clinic in Virginia, and I had been there for a while. Up the road from us was an assisted living facility with probably 20 patients in there. And many of the people were quite functional. Of course, they were elderly. But they would sit around, they would play cards. They sometimes went on trips. They had programs for people coming from the outside. Anyway, I have one patient that would come and see me at our office. And one day she came in and she was 92, I believe, 92 or 93. And she was still playing cards every day and having a good time. But this particular time, she was really ill.
You are listening to the ACP for AA podcast. More coming up after this quick break.
If you faced a healthcare emergency today that made you unable to communicate, would your doctors and loved ones know your medical wishes? Sharing healthcare wishes with loved ones is a valuable gift to those closest to you. Get started now. Visit acpforaa.org.
Montgomery Hospice and Prince George's Hospice is a nonprofit healthcare organization that provides hospice care to residents of Montgomery and Prince George's counties in Maryland. Our interdisciplinary team includes physicians, nurses, spiritual counselors, hospice aides, bereavement care, and volunteers. And we also provide complementary therapies. To learn more about our services, please call 301-921-4400 or visit us at www.montgomeryhospice.org.
But this particular time, she was really ill. She was short of breath and coughing up stuff. She had a fever. And I told her, I said, I think you ought to go to the hospital. You probably have pneumonia, you're elderly, you could die from this. I don't want to go to the hospital, she said. I'm not going there. I am ready to die. And that's okay with me. So along the way, I treated her with some breathing treatments to help with her breathing and gave her an antibiotic. I actually gave her an injection. And she went back to the assisted living facility. The next day I went just to check on her on my way home. And she was pretty much out of it. She was breathing hard. And by that time, her daughter, who was from Alabama, came up to visit her. And she hadn't seen her for a couple of years. And when she saw her, she panicked and she sent her to the hospital. she wanted her to go to the hospital. Now, I had told her, I said, your mom wanted to stay here. She said she was ready to pass away. So this patient goes to the hospital and ends up getting what's called a chest tube, which is a tube that's put in the space between the lining of your lung and your lung tissue itself, to drain bacteria. And then she was also put on a ventilator. She had these treatments for the next 5 days, and I came to visit her actually after they took off the ventilator. And she was a little bit out of it, but when she saw me, she looked at me and said, "Coleman, why did you let them do this to me? You knew what I wanted." And I said, well, yeah.
Wow.
So I said, it was your daughter, she hadn't seen you, and that's the way it was. But the point of that is that I never got anything signed. I hadn't even thought about an advance directive and didn't think about it much then. There was nothing to show her daughter. It was just really what I said and what the people at the assisted living facility said. And I realized that it was a shame. This woman did get discharged from the hospital, and about a week later, she died.
Wow. Wow, that's quite a story. And it is unfortunate that her wishes were not initially kept, because even though she had told you what she wanted, you didn't have the paperwork to back that up.
No.
And because there was no paperwork, no formal execution of her wishes, her daughter just had the say so in what her treatment would be. And that was against what she wanted. And that's unfortunate, but I'm sure it happens quite often.
It does happen quite often. And you may have family members that are taking care of someone nearby and realize that their mom doesn't want to go to the hospital, but somebody comes in from out of town, another relative, and says, "Oh, what happened to her? You need to do something about that." And that's when kind of the conflict and the drama starts, especially if there haven't been any directions concerning this.
So I have a question then, because your work in hospice and palliative care has been so instrumental in helping hundreds of families right now and in your past cope through these difficult seasons of loss and dying and grief. How and when do you usually advise them to have that talk? And is it ever easy?
The best time really is when the persons are well and there's no stress that's occurring. You really want to have them when you're not in the hospital or you're not very sick. It's a lot better to do it when there's not a lot going on. Sometimes that's not possible, but that's probably the best time. I usually tell people to have these conversations, let's say after they have a relative that may have gone to the hospital, and saying, "Dad, what do you want to have done?" Or, "Mom, would you want to go to the hospital and be like Aunt Sarah?" And that can be a starting point for some people to see what kinds of treatments they may or may not want. So funerals are a good time when someone's ill, or when there are other ways that you can start conversations like that.
From your experience, when you help families have these talks or start these conversations, has it ever been easy?
I think sometimes it is, because from many people have actually already made a decision who have chronic illnesses, and they haven't expressed it to anyone, because expressing it among African Americans seems to make it so. And so they want to have faith that they will be healed or that they will live. But a lot of times there are many people that do want to talk about these things and want to share them with their relatives, but don't get the opportunity to do so.
I know that with the living will or the advance directive, that it only comes into effect or into play if and only if the patient is unable to speak for themselves. I think that for some, there may be a misunderstanding about when this would take place. When does it take effect? And for all, it may never be necessary to enact the advance directive. Can you tell us a little bit more about what it is patients and individuals need to know about those end of life or advanced care plans that they're making to help clarify those little points about when it's effective, who can make decisions for you, how to go through the process?
Well, there are several types of documents when you do advanced care planning. The first one is called the Healthcare Power of Attorney. And what that does is that you designate someone and a backup or several backups to make decisions for you if you are not able to make decisions for yourself. Now, you can specify in that document that you just want them to take over, even though you are cognizant and able to make decisions for yourself. But sometimes someone wants other family members to do that. But most of the time, it's when the advance directive goes into effect or the living will goes into effect when the person is not able to make those decisions. So that's called the healthcare power of attorney. In some of them, it has specific instructions about things that you may want or may not want. And that's where you call what's called the living will. You not only have the healthcare power of attorney in it, but also specific treatments you may or may not want.
Okay.
And so you may not want to be on a ventilator. You may not want to go to the hospital, or you would agree to surgery, or you would agree to whatever treatment may be. Some people just want to be kept comfortable. Some just want to be at home. And so you would specify that in the living will portion of a document like that. Now, any of these documents can be revoked or stopped at any time. You can, if you are able to make a decision for yourself, it is not written in stone that you have to use it. You can say, I want to do this and not do that. Because of the fact that many times it doesn't discuss all situations that may come up with you. So you may have to make decisions or you may want to revoke that document along the way. The last one generally is the one that's the least used, which is what's called a MOLST or a POST form, which is for medical orders for life-sustaining treatment. Usually that's a doctor's order, and it has specific things about whether or not you wanted to allow natural death or whether you want CPR, a ventilator, dialysis, feeding tubes, and those sorts of things. So the documents can be changed at any time that you wish, and you can give other directions to them.
So based on those options, it seems as if a patient would have a lot to discuss with a doctor, medical staff, and also with their families. I can see where the doctor-patient relationship is going to be very important for the patient to trust that their doctor, has their best health in mind. The doctor-patient relationships are vital to one's health. And I liken it to the trust test that I've seen in movies where someone in a group is asked to fall backward and to land in a group of people waiting to catch them. And it's always a disaster in these movies because inevitably someone doesn't get caught. They fall on their face or their butt or something. It's always a disaster. It just never goes well in the movies. But when we put our health in the care of our doctors, we expect that if it falls, that our doctor will help catch that. And that may be an unusual example, but that's where my mind goes when we're talking about trust and feeling vulnerable to what our doctors have for us. Have you, in any of your experience with your patients, talked about the trust in the care and had patients that bring up concerns for themselves, that advocate for themselves?
Absolutely. People need to trust in the person that's going to make decisions for them, and preferably pick someone that's not going to panic and is willing to stick by with whatever your wishes are. The other thing is with healthcare providers, not all of them are used to talking about end-of-life issues either. And so you may have to bring it up to your provider, these issues. And there are ways to do it. The easiest thing to do is ask about having an advance directive. Do they have any paperwork, or can you tell me about that and what to do? And hopefully that person will take the time to do so in the process. The time that it takes, like I say, it may be an ongoing conversation over several periods, and hopefully you have a long-term relationship with the person. However, a lot of people, what will happen is that they will not have made any decisions. They will end up getting extremely ill. For example, during COVID-19 pandemic, many people had respiratory failure, ended up in the hospital, were not able to speak for themselves, and had no advance directive. It was hard to get in touch with families. And so providers are really left on their own to try to figure out what to do. And usually they will do everything that they can unless there is some other documentation.
Okay. You were speaking about the pandemic, and we're aware that initially in the beginning time of the pandemic, African American mortality count was higher than other ethnicities. And it begged the question of why. And what we started to see was a push for advanced care planning, because there's such a gap in the utilization of hospice and palliative care, for one, between the African American community and non-African American community. And that gap needed to be bridged. So we have now a conversation that's happening more publicly, more openly, about healthcare disparities, about gaps in healthcare by ethnicity, and a conversation about how do we bridge those gaps. And one thing that comes up is representation in the medical field. And certainly the diversity count is up in all fields, and representation does matter. But still, in some African American communities, they'll have doctors, nurses, and medical staff that doesn't look like them, and that just only may highlight that mistrust that we spoke of earlier that's rooted within the culture. Based on your experience, can you tell us how someone can overcome those issues and still build a good relationship with their doctor despite any differences in culture, how to have that conversation with the doctor and bring up those differences that your culture may be from what the doctor's culture may be?
I think that you have to find a provider that you can identify with. And sometimes that may be changing doctors. There are some that may take a lot of time with you. that don't seem to have a lot of patience or understand you. And I think that many folks do have that sense when they see their doctor. They know who cares about them and who doesn't. One of the ways that you can ask your primary care provider is, who will take care of me if I get sick? The other thing is, you need to have someone that will forcefully advocate for you, that will try to follow through for your wishes. And sometimes takes a loud voice. It sometimes takes repeated trials to do that. And hopefully you will have the time to do so along the way. I think it has improved over the last few years, but it still has a long way to go. The presence of implicit bias in care is still rampant. And it is hard to get beyond that at times.
So being able to speak up for yourself and advocate and actually be bold enough to say to your doctor, who hopefully you have built a rapport with, this is what I would want. How do I document this is crucial, because if you don't do that, then those decisions are left up to other people.
You are listening to the ACP for AA podcast. More coming up after this quick break.
ACP for AA is a nationwide educational outreach initiative, partnering with organizations to help bridge the racial disparity gap in healthcare delivery by providing credible and culturally relevant healthcare-related information and resources, promoting conversational engagement about advanced care planning options and preferences, and preparing the necessary steps to complete advanced care documents and choose a healthcare advocate if unable to speak for oneself. ACP for AA, an initiative of Heart Tones, is pleased to partner with Montgomery Hospice and Prince George's Hospice Center for Learning to provide ACP resources to citizens of Montgomery and Prince George's counties in Maryland. Visit acpforaa.org. And advocate and actually be bold enough to say to your doctor, who hopefully you have built a rapport with, this is what I would want. How do I document this is crucial, because if you don't do that, then those decisions are left up to other people. I wanted to get into a little bit more about how families can get that conversation going. Once a patient knows how their decisions will impact their end of life care, and they're decisive on what they want, and they set that plan in place, then they want to have this conversation with a loved one. They pick someone who, like you said, is willing to speak up for them, willing to push against any force or friction to having their wishes made and done the way that they want, and someone who won't become anxious or nervous about it, who will actually stay calm and weather the storm well. It will be a trying time. For many it is. And so I just want to know, what do you say to families who have that part in place? They have the paperwork, they've talked to their doctors, and now they're ready to talk with their loved ones. What do you say to them?
Well, what I suggest, and this is an easy way to bring it up either way, and that is to tell your son or your daughter where your important papers are. You show them what they are. Or like I did with my father, or actually my father did with me more so, is we were sitting on a couch one day before he passed away, and he said, "Go get my suit jacket." And he had cancer. He had head and neck cancer. And so I went and got his suit jacket. I knew he was dying. And so in his suit jacket were his advance directives. He said, "Pull it out," and also a bunch of $2 bills but that's another long story. He said, don't do anything to me that I don't want done. I don't want to be on a machine and this and that. Now, I was in this business,
Right.
Still had a hard time dealing with it, but he showed me the way. He had the paperwork already. He wanted to show me what he wanted, where his things were, where his important papers were. Or you can ask mom and dad, where is the life insurance policy, or where is the living will? Those kinds of things. Oh, you don't have one? Oh, maybe you should think about it. I mean, and that's a way to get it started. Or you can ask them, can you help me with something? And say, well, I don't want to talk about the dying now. I mean, he said, well, when is a good time that we could talk about it? When will it be better? What do you need to have to think about to make it more comfortable for you?
I think those are all really good starting points for the conversation. I once heard it said that a good place to kind of keep your documents is in a freezer, because, in the back of the freezer, under all the food and all of that. That's an aside from our topic, I think. But thank you for sharing your personal story about how your father did that and giving those tips on how to get the conversation going. The impact of these conversations that we can have with ourselves, with our doctors, and with our loved ones is seen and felt in how a person actually experiences those end of life or those final days that they have of life. And we want our listeners to hear this and to take heed to what we're saying, and also to take those steps to complete the advanced directives. I want you, if you're able to share a few real life stories of families that did have those conversations and that didn't have those conversations, and maybe tell us how it impacted the families and how it impacted the patient.
I can tell you some very horrifying stories at times. I can recall an actual, I think there were 4 or 5 sisters or brothers. 2 of them were estranged, and they came from out of town to see this family. I mean, to see their mom, who was passing away from cancer. And I remember being outside of the house, and then a fight broke out inside, and they called the police. And the police asked me, well, what do we do? I said, I don't know, but this is the kind of stuff that can happen, the kind of drama you can get into when you're talking about end of life issues and people are not in agreement. And sometimes it's hard to get everybody involved. In the African American community, we tend to be a tight-knit family, and loved ones want to have other people involved. And so we have to make our wishes known to try to avoid that kind of drama.
Right.
Another extreme is that, there's some places I've gone to visit, and the patient and the caregiver, whoever it may be, the spouse say, we're ready. And they actually said, we want to be comfortable. I want so-and-so to be comfortable. And they hand me the advance directive. Make sure that this happens to me or doesn't happen to me. Make sure you do what you're supposed to do. And I try to fulfill those wishes. Sometimes they will ask me I've had to talk to other family members about what mom and dad want because they don't agree. I have a situation right now where I'm talking to the kids about chemotherapy. Their dad is still going through chemotherapy, and he is really suffering from it. And he keeps telling me that he wants to stop, but his kids don't want him to stop because they don't want to lose him. And it is not doing him any good at this point. I'm seeing him on a weekly basis and trying to treat his symptoms, and he just seems to be getting worse, more bedbound. Soon he won't take it anyway. So,
wow. It's quite interesting to see the different dynamics that come into play by preparation or a lack thereof of preparation. And it definitely impacts the family, at that end of life point with their loved one. So just taking back to what we were listening to with the clip between the mother and the daughter. In that clip, we have determined that there was a starting place. We got a little bit of information from it, but that was an ongoing conversation. So I invite our listeners to create those goals, the goal of creating your advanced care plan and solving that question mark. Thank you for joining me today, Dr. Coleman. I just want to get your final thoughts. What is your final appeal to our audience that will help them get their house in order?
I would ask just to start the conversation. Realize that it will take time and it may occur over several encounters, and try to take what you can from it, even if it's not written down. I know when people see advanced directives, they think that's in stone or that's permanent. But even just knowing what your loved ones want and then being able to express that to some provider, to some doctor or a nurse, can be helpful to try to get the care that person needs. It makes it less stressful for the patient and less stressful for the family, less suffering for everyone involved.
Amen to that. I just want to thank our special guest, Dr. Coleman, for joining us today and giving us that helpful insight. Thank you also for listening today. And we know that this is not a topic of popular discussion, but the cycle of life is inevitable, and talking about it is so important for all of us to do in advance while we still have life and while we still can. Discussing your end-of-life wishes eliminates the guessing game for your family and physicians in the event that you're not able to speak for yourself. So for more information about this process, we encourage you to purchase a book written especially for the African American community called The African American Spiritual and Ethical Guide to End-of-Life Care, subtitled What Y'all Gonna Do With Me by Dr. Gloria Thomas Anderson. It's on the CDC's recommended reading list for advanced care planning, and we recommend it too. Also, visit our website at acpforaa.org. That's acpforaa.org. This podcast is brought to you by a collaborative partnership with Montgomery Hospice, Prince George's Hospice, Center for Learning, and Hearttones Inspirational Company to raise awareness of advanced care planning for the African American community. Our hope is that this podcast helps you feel supported, confident, and ready to have that much needed conversation about advanced care planning in advance. If the information you just heard supported your needs or helped you in any way, we invite you to pay it forward and to share this podcast with someone else who needs to know what you now know. And also use our hashtag ACP for AA to have that conversation online. Join us again for another episode of Getting Your House in Order right here on this channel. I've been your host, Tracy Holloway. Thank you again.
Well, that's it for this episode of the ACP for AA podcast. Thank you for listening. It's a good time to plan. That is to prepare for life after now. Visit the acpforaa.org website to view our webinars and to download other helpful resources to prepare your ACP. And remember to follow, like, and share at ACP for AA on social media. Until we meet again.